So Sadguna, please start.
Good evening, teachers and friends.
Yeah, go ahead, please.
Okay, sorry. So I'm discussing a case of 18-year-old female studying BCom now. She's from Chennai, unmarried, and informant being self and mother reliable. She came with chief complaints of loose stools since 6 months and weight loss since 4 months. A history of presenting illness. She was apparently normal until 6 months back when she had a basal stool frequency. Baseline stool frequency was 1 to 2 per day, and with consistency being Bristol 3 or 4. And for the initial 4 months, her complaint started as loose stools 3 to 4 episodes per day for about 10 to 15 days per month, and it is watery nature, and Bristol 6 or 7, large volume, associated with nocturnal frequency of 1 or 2 stools per night. It also contains
It's a large volume. Good evening, madam. Good evening.
NVK, this case is yours or it is the students?
Huh? Cases from students.
Okay, no, the person who's presenting is the person who's seen the case, or I want to know that because they're having problem with the bias, they're not able to discuss anything beyond. So who, doctor, what's your name? Sadhguru, this is your case you have seen?
Yes, ma'am. I have seen this case, ma'am.
Okay, so you will not discuss, okay? Just take the next person. VT, request the next person to take up the discussion. Present the case and discuss.
Who is the next?
Yeah.
Sir. Jovita.
Sai? Who is there?
Hello.
Maybe
Hello, sir.
Sadguna can present it and then the next person can discuss it, no?
No. What I
Clarification on the history will not be possible.
No, what I suggest is that 1 minute, VT, Sadhguru, he can take up the discussion for the next case, and then we can ask him investigations. Why did you do this? Why did you do that? I mean, he's taken the history, then he knows all the case differentials will just be the same. And last time we had this, you remember, we never went beyond a CA stomach or a gastric outlet obstruction. Last time also I said, let him participate in the next presentation, no? As a present. This is always better. That's my feeling. If you want to do it this time, finish it off. But next time, I think do it this way.
Okay, Sadguna, you present the case, and after that we will ask others.
Okay, sir. For initial 4 months, her complaint started as loose stools 3 to 4 episodes per day for about 10 to 15 days per month, watery with consistency being Bristol 6 or 7, large volume. So, are you able to hear, sir?
Yeah.
Yes, sir. And large volume stools, 1 to 2 nocturnal stools, along with small amount of mucus occasionally in about 1 to 2 stools per day whenever she is passing stools. During initial 4 months, she didn't have any blood in the stools. For these complaints, she was
one interruption. You said it started off with the 3 to 4 episodes per day. Was it an acute onset, sudden onset? That is what we are interested.
No, sir. Actually, for initial
insidious onset of diarrhea with 3 to 4 episodes, large volume, watery,
yes, sir.
with nocturnal symptoms. Okay.
Because of initial insidious onset only, for about 15 to 20 days, she did not seek any medical attention. Maybe later, she has taken over the counter and also local physician treatment she has taken, sir. So she was treated with 2 short courses, that is of antibiotics for 5 days each, which was 1 month apart.
I'm going to ask a question here. Tell me when you can get watery diarrhea with large mucus, large watery diarrhea and large amount of mucus. Give me some causes. When can you have this presentation? Large volume of watery stool and large volume of mucus. What are the thoughts in your mind?
I'll be thinking of irritable bowel syndrome.
Please don't answer the chat box, okay? I just want to know, in a day-to-day outpatient clinic, a person with watery diarrhea, will you ask for history of large mucus or mucus present in the loose stool?
Yes, ma'am.
Or give me the causes when you can get large volume diarrhea and also large volume mucus. What?
Sadhguru, did you understand the relevance of the question?
Yes, sir.
Because
Yes, sir.
whenever there is a large volume, we think it is a small bowel disease.
Small
you know?
bowel.
And whatever mucus at all there is will become completely diluted and we won't be seeing it. But there are certain situations where the diarrhea can be large volume, still mucus also can be copious.
Well,
There are only few conditions.
Yes, sir. Villus adenoma of the left colon or distal colon.
Okay.
I was initially, and if the large volume with large amount of mucus, was not sure, sir. I was thinking that if it was a small amount of mucus with diarrhea, I was also thinking of irritable bowel syndrome.
IBS, do you know the various synonyms for IBS? At
Mucoid
one point
diarrhea.
of time, IBS was actually called mucus colitis.
Mucus colitis. Yes, sir.
As it evolved, because we did not know what it was. So at one point of time, it was called mucus colitis because people thought there was an inflammation and some people, and especially people with the diarrhea tend to produce a lot of mucus. Okay. The diarrheic variant can also produce a lot of mucus. Can microscopic colitis variant come with mucus?
Microscopic colitis usually presents with watery diarrhea, sir. But occasionally small amount of mucus can be present, but
Okay.
large amount of mucus, I'm not sure, sir. And age of presentation also it's not.
To my mind, okay, villus adenoma affecting the rectum or the left colon is the most common because it can produce a secretory diarrhea and it can also have a lot of
use mucus.
Mucus.
This is a straightforward answer. Other conditions should be equally rare. But IBS also, some people with IBS tend to have watery diarrhea. They tend to have predominantly watery type of diarrhea and they can also have mucus.
In the
Shall we
water,
proceed?
how did
ma'am
she
is
pick up
there.
the mucus? In the water,
Ma'am,
how
we are
does
not
she say
able to
there's
see you.
mucus? In the water, how does she say there's mucus, no?
Yes, ma'am. She
How does she say it?
definitely
Watery
told that
diarrhea,
initially.
One minute. The watery diarrhea will get mixed with the water in the closet.
Yes, ma'am.
So the diagnosis is only villus adenoma rectum, right? That's a diagnosis in this case, right? We have no other differentials. Because,
What are the ways in which the persons will say that detect mucus? How do they know it is sort of, one is visual. Is there any other method by which they can feel it?
VT, other thing is nocturnal diarrhea and villus adenoma, no? I mean, all these things, what I'm trying to say is, I'm just thinking in an outpatient clinic, I was just thinking aloud, in an outpatient clinic, will I ask for, in a watery diarrhea, will I ask for blood, will I ask for mucus, probably I'll ask for nutritional deficiency, think whether it's osmotic, or is it, I'm just thinking aloud, or secretory, my mind will go, or is it hyperthyroid, is hypo, that mucus bit will not come at all in my mind. I do not know how many of us.
In the next 2 months, there was copious amount of mucus, ma'am. That's why retrospectively, I asked her whether you had any symptoms prior to that, or is it only for the last 2 months you had the mucus?
Then stick on to the mucus, no? That's all. Stick on to the mucus.
Okay.
They can see it, but if it is too watery, they will be finding it extremely difficult to see. Actually, when it is semi-formed or formed, they can actually find a lot of mucus, especially in IBS. The other way they find it out is that the feeling of sliminess of the perianal region when they clean it.
And especially when
Usually,
you wash,
when
you
they
can
wash
feel
it, it will be clean, but they feel it is slicky, slimy, etc. This
What's
may
the
happen
source?
for steatorrhea as well, but mucus also can produce same sort of picture.
What is the source of mucus? Can mucus be normally present?
Yes, ma'am. Mucus can normally be present, ma'am.
Produced by what?
Produced by the colonic mucus glands,
Colonocyte.
not
Name of those
colonocyte,
cells?
ma'am.
Not colonocyte, which cell?
Which cell produce mucus?
Produce, which cell in the thing will
Generally, goblet cells produce mucus, sir.
blood cells produce. Right.
So normally itself it can be present. IBS patients also present with
Yes, ma'am.
mucus.
IBS patients also will be present.
Can it be solitary rectal ulcer syndrome? Which you're thinking, no? Mucus.
Yes, ma'am.
But large watery diarrhea. Anyway, move on.
So,
Yeah, go ahead. No blood in stools. And then she was treated with 2 short.
it was a short course of antibiotic, which she didn't remember because in the initial 2 months she was treated, which she has taken 5 days each, 1 month apart, sir. She had partial relief for about 1 or 2 days, but she did not get relief completely. For these complaints, she herself kept on fasting for 1 day, 1.5 day, like that, sir. But at that time, she claims that symptoms partially improved on fasting, sir.
Fast.
But
So
the
what does it
next 2
suggest?
months,
When
because of
somebody is
large
fasting,
volume
improves it.
diarrhea, because it is large volume, small bowel. I was thinking, sir.
No, what about what?
Osmotic diarrhea.
What is it? Wait. If somebody has got a chronic small bowel diarrhea, large volume diarrhea, and fasting reduces diarrhea, what strikes you first? What sort of diarrhea?
Osmotic type of diarrhea will
So
be.
she might have a small absorption. Okay.
Yes, sir. So for the past 2 months, loose stools are daily, sir. Large volume stools, 10 to 15 episodes per day. Watery. She was telling that most of the times it is watery. Otherwise, she is getting copious amount of mucus. This is what the descriptions. And nocturnal frequency also increased, requiring admission in the last 2 months twice, which was treated with IV fluids and some other IV medication, probably antibiotics. And she also had small amount of blood mixed with stools on few occasions. For about 3 to 4 times, she told that small amount of blood she passed. That was not fresh blood. Along with the mucus, a little bit of staining of the blood was present at that point of time. And it is also associated with urge to pass the stools and pain at the perianal region, which was relieved after defecation. And since past 2 months, there is no improvement with fasting. She tried, but she did not get any improvement with fasting.
This time it is not improving in fasting.
No, sir.
How many times during day? 10 to 15, and the night
Total
also?
10 to 15 days.
The night?
Night 3 to 4 times she was
Okay.
waking up, and almost for the past 1 month, her sleep also got disturbed because of this completely.
All right.
Okay.
And she lost about 11 kilograms of weight over last 4 months. She quantified only for the past 4 months and decreased.
She's a
Sir, ma'am?
She's a homemaker.
No, ma'am. BCom, she's a student, ma'am.
Student. How often she's absented from school, college?
From the past 3 months, she is absent from the college, ma'am.
How old is the patient?
18 years old, ma'am.
Okay, come on, let's discuss then. Okay, continue. I think the discussant has to be someone else. Okay, that's my feeling.
Okay.
Since last 1 month, she also developed swelling up to the ankle level. She also complains of bilateral ankle and low back pain for the past 2 months, which is more on waking up. On the back pain, she was more telling like stiffness, morning stiffness, which has partially improved as day progresses. Her physical activity is limited now for the past 1 month to limited self-care and also bedridden more than 50% of the time because of weakness, it seems. Generalized weakness, not because of the pain or stiffness of the back. No complaint of pain abdomen during this entire history. No complaint of abdominal distension, no fever, no foul smelling stools, no excess flatulence or borborygmi, no greasy stools.
So with
what are the important history you'll ask in an 18-year-old girl who's going to the college and passing 18 to 20 times stool per day and passing 2-3 times at night? What is the intake like?
It to less than 50% of
Why?
Initially she tried voluntary fasting, ma'am, because she thought that it was improving with fasting, but for the past 2 months her appetite has been decreased, it seems, ma'am. That's why her intake has decreased to less than 50%.
So it's going to just not
appetite was
harp on that fasting business alone, because subsequently it did not have.
Did not,
So, see, there is one dominant picture in this patient, that is the excess, the frequency. See, for a small bowel type of diarrhea, this much frequency is not possible.
Omni, she'll get hospitalized.
Yeah.
She'll get large
Hospitalized
volume. She'll get
twice, ma'am.
hospitalized. She'll be in the hospital for all the 2 months.
She was hospitalized
She was
twice,
hospitalized multiple times, no?
twice.
And
And
given
she
IV
required
fluids.
IV fluid.
Hospitalized for 7. Once she was admitted for 7 days. The second time, last time she was admitted for 4 days.
What history will you ask for dehydration? 12 to 13 times large volume diarrhea. What history will you ask for dehydration? Because we need to know that.
Like, but now whether she has excess
No,
thirst
day before
or
yesterday, on my day before yesterday, I had diarrhea.
Standard questions you should ask when
One
you have got a
minute,
large volume diarrhea.
BT, I'll just tell about myself. Just day before yesterday, I could not even attend the class. I had about 8 to times watery diarrhea. It was just water, okay? I collapsed. Okay, it was just short of going into the hospital. So that is the state of affairs with one episode. This is, I'm talking of frequent 3-4 times lasting for about 2 hours. I almost literally collapsed. Here you're talking large volume, 10 to 12 times per day and 2 to 3 times at night. So be very careful in your interpretation of the history. Okay, I'm just thinking, I'm not finding fault. I'm just thinking of the consequences, how the patient would be with this much of diarrhea and this much of, okay.
So she's
Okay,
not.
Sadguna, one is the thirst you mentioned. Anything else? The other symptoms may have mentioned, that is giddiness and features of postural hypotension. Third one?
oliguria,
Oliguria, yeah,
present,
diminished
sir.
urinary. Yes,
And
correct.
any altered mentation or confusion.
Yeah,
That is
that
the
is the,
severe,
when there is hypotension
That's
and
whenever
other
there
things.
is a
Electrolyte
hyponatremia.
imbalance and yeah.
And thirst.
thirst. If
So
the
excess thirst,
excess thirst is there is an
oliguria,
early some
postural
dehydration.
giddiness, then obtundation or altered mental status due to hypotension plus electrolyte imbalance.
Hyponatremia.
Yeah. Okay, go ahead. But one thing, usually there are so many no's, but the next slide.
This is for etiological thing I kept, sir, because at this point of time I was thinking of
In the
small
GI
bowel.
tract, do you want to consider any other no? That's it, previous.
In GI
Normally we
tract I
can,
considered
so abdominal pain,
periabdominal
abdominal
fever.
distension, fever, foul smell, excess, etc., etc., etc. You mentioned. So this duration of illness is now for how many months?
6 months, sir.
And you 6 months, and there is weight loss. And that's a small bowel type of, at least large volume diarrhea. We don't know small bowel, large bowel, or mixed.
It's watery diarrhea. So it's watery diarrhea.
And then there is a pedal edema. Pedal edema now.
Yes,
With all these things, should you ask for some more negative things to rule out?
Laxative abuse.
no laxative abuse, ma'am. Apart from the oral antibiotics and IV medication and IV fluids.
Is there any
other medication
deficiency,
prior to
any
this,
symptoms of deficiency of micronutrients?
that I mentioned, sir. So
You mentioned it?
there were, yes, sir. She didn't tell orally. On examination, I have examined. On history also.
No, on the history part also, because there is profound weight loss, pedal edema, and this pedal edema is most likely due to?
This pedal edema probably due to hypoalbuminemia.
Okay, that means
deficiency.
that means profound protein loss is there. Okay,
Yes,
so
Laxative abuse is there?
no, ma'am.
How did you get that history?
Actually, previously any constipation or any abnormal personal psychiatric behavior. Informant mother also was there, ma'am. So I asked her regarding
Mother will not know, doctor. How do you know that this is, I'm telling you, it's a laxative abuse.
Okay.
How will you know? I'm just wondering, 18-year-old girl with that diarrhea, that behavior, I'm just wondering.
Yeah, but if there is pedal edema, profound weight loss and all, it has to be organic. No?
Lack of intake, no?
Can we proceed?
And there is No history of high risk behavior, blood transfusion or tattooing, no cough, hemoptysis, chest pain, evening rise of temperature, tuberculosis history, no history of allergies or seasonal variation, oral ulcers, genital ulcers, or skin lesions, no antibiotic uses prior to the onset of the loose stools, no history of extraintestinal manifestations like eye pain, apart from the inflammatory back pain and ankle pain. There are no eye pain, discharge, skin lesions, a perianal tenderness, swelling or discharge from the perianal region.
What is in your mind when you are telling no history of allergy or seasonal aggravation?
Eosinophilic enterocolitis.
What is that?
Eosinophilic.
Eosinophilic.
Eosinophilic enterocolitis.
So is it eosinophilic enterocolitis? Is it related to pollen allergy and other things? Seasonal?
No, sir. No, sir.
No.
No other allergies. I meant.
Okay. What about no recurrent URTA or LRTA? What was in your mind?
Regarding combined variable immunodeficiency, I asked. So though this type of presentation involving colon and small bowel is rare,
Okay.
but large volume of diarrhea still at this age, I wanted to.
Next slide.
Past history is there. There is significant past history. At the age of 8 years to the patient, she was diagnosed to have ITP. She told orally when she had skin purpura and was given immunoglobulins during the admission, and then oral steroids were given for 2 months taper, and after that she was followed up for 3 years with the blood counts, and then no such issues and no follow-up after that. So from 8 years of age to 11 years of
age.
age.
ITP treated with immunoglobulin and steroids. Okay, at the age of 8. Next.
And family history, no history of any cancer or cancer-related death in the family, no history of tuberculosis in the family, TB contacts, or inflammatory bowel disease. She was born out of non-consanguineous marriage, full-term normal vaginal delivery. She has a younger brother, 14 years, healthy. Menstrual history, she attended menarche at 12 years of age. Cycles were 2 to 3 days. Once in 2 months only she used to get in the last 6 years. Normal volume. Since 6 months, she did not menstruate. After the symptoms started, she did not menstruate at all. Before the onset of the symptoms, she had mixed balanced diet, probably. But now the caloric deficit of 800 kilocalories and a protein requirement 35 gram protein deficit she was getting. For these symptoms, she was evaluated in an outside hospital by blood investigations and colonoscopy and told to have low blood counts and some bowel problem, given oral medication for 1 week and IV fluids for 3 days. Her symptoms were not improved and came here for further management.
Okay.
They could not come to a
next slide is summary slide.
Yes, sir. Summary slide.
Okay.
So 18-year female with past history of ITP presented with 6 months history of large volume diarrhea with mucus and occasional blood associated with decreased appetite and significant loss of weight, inflammatory type of back pain and ankle pains, along with menstrual irregularities with features of malnutrition in the form of pedal edema with performance status ECOG 3.
Can you make the menstrual irregularities amenorrhea? Make it straightforward.
Okay, sir.
Because menstrual irregularities, a person who just reads your summary should be confused. So there should not be any confusion. Say it amenorrhea.
Amenorrhea.
Did the ITP recur again?
No, sir. No, sir. She was only followed for initial 3 years, but she was normal. After that, she had no complaints. Only now, in the last admission, they found that there are some low blood counts.
Jovita Preeti, are you there?
Yes, sir. Yes, sir.
Can you summarize? How will you summarize? Do you agree with this or do you want to present it differently?
18. I agree.
You are happy with the summary or do you want to add on to it? Delete some parts?
Large volume.
No, you don't,
So
don't
not
want to
not
change.
not just large volume, increased frequency.
No, that only has initially mentioned, no?
Okay.
Maybe some frequency need to be added. Okay, with the very high stool frequency. That is not there. Okay. And towards the fag end, there are is there any tenesmus actually?
There is no tenesmus, sir.
Sadguna, you said the patient
No, sir. No, sir.
needed to go to toilet every now and then. It is only the frequency, not
Only
tenesmus.
the frequency, sir. No tenesmus.
Okay. So as ma'am suggested, the next person, thank you Sadguna for presenting the case. The next person will discuss the diagnosis.
Okay.
Just leave it at summary. Jovita,
Yes, sir. Yes, sir. So,
do you want any clarification from Sadguna regarding the case history?
no, sir.
If not, okay, no, we'll proceed.
Yeah, no.
Okay, discuss.
So my differentials will be in
Now, what do you
inform-
think? What do you think has evolved? You have to tell us which system is affected. What is actually happening? So what
affected
happened 6 months
system.
ago? Then what happened then 2 months later? And what's happening now?
No.
This is the thing which has evolved over a period of 6 months. So
Okay,
tell
sir.
us what all things have happened. And then the syndromic diagnosis and finally the etiological diagnosis.
Okay, sir. Initially, it was it's a chronic diarrhea, large volume, and initially the frequency was only twice during
No,
night
that's okay.
time
You
and,
tell us what she has got. You know all this.
involvement of small bowel and large bowel.
What are your points in favor of small bowel involvement?
Small bowel involvement.
It's large volume, watery diarrhea, and initially had some improvement with fasting, suggestive of an osmotic component.
Osmotic component in the sense you mean to say extraneously administered osmotically active substance. Is that in your mind?
Yes, so maybe some transient lactase intolerance or
So
something.
how does when somebody is not eating,
Oh.
he may not be also taking the osmotically active substance.
Mm.
Apart from that, how does fasting improves osmotic diarrhea? Any other method? First is straightforward, not taking anything orally. That means osmotically active substance also is not taken. For example, lactose intolerance. The person doesn't take, the diarrhea doesn't happen. Is there any other method by which, is there any other mechanism by which an osmotic diarrhea stops due to reduced food intake?
Not sure, sir.
Actually, malabsorption actually produces lot of undigested particles in the small intestinal lumen. These are highly osmotically active. Each molecule will attract each molecule of water, each molecule of undigested substance remaining in the small intestinal lumen. So in a malabsorptive state, there will be a combination. It's not a pure secretory or osmotic diarrhea. It's a combination. There will be a lot of secretory component. There could, if there is a mucosal inflammation, especially, or if there is a significant malabsorption, there will be an osmotic diarrhea secondary to the malabsorption of partially or fully digested food material. Okay,
Okay, sir.
that is one mechanism. Okay, you said therefore it is small bowel and probably it is partially improved. Do you think it is that's an osmotic component? Up to that we agree.
Okay.
So she's got a small bowel diarrhea. What do you think? Why do you think she's got a large bowel involvement?
Now
I
what
thought
did she
she
have?
had increased frequency up to 15 times with mucus and small amount of blood and perianal pain.
Okay. But there was no
So-
pain. It's a painless diarrhea.
Painless diarrhea.
Okay.
So small and large bowel involvement is there. Then there is features of protein losing enteropathy or reduced protein absorption, malabsorption in the form of pedal edema. And there is a feature suggestive of inflammatory oligoarthritis,
Okay.
bilateral ankle and low backache, which improves with activity.
So,
and there is
okay. Therefore, you can add everything together and tell us which all parts.
What are the problem diagnosis you got? What are the problem diagnosis? Large volume.
probable diagnosis in the in a young female with significant anorexia and weight loss,
Doctor, you just tell me that.
and IBD,
IBD have different
probably
types, no?
Crohn's disease,
Crohn's
because
disease
of both-
affecting which parts?
the jejunum, ileum,
So
and
Crohn's disease of the small intestine, large intestine. So
small
extensive
intestine and
involvement
large
of the
intestine.
small intestine, large intestine, plus is there any
Plus,
other manifestation?
extra intestinal manifestation in the
In
form
the
of
form of?
joint pain,
So you think there's a small
and
bowel Crohn's?
pancytopenia. Yes, sir. Small and large bowel.
So you got involved in small bowel Crohn's. Small bowel Crohn's, how does this produce diarrhea? So much a volume of diarrhea. And she has no pain.
It's a painless.
You would have seen many cases
And
of
they said
Crohn's
there's
by
no
this time.
borboring. There's no borboring.
Mhm. No features of any
How does
distal structure.
Crohn's disease produce small bowel diarrhea?
Jovita, have you seen a similar case of Crohn's disease in the last 2.5 years?
Yes, sir.
The exactly same picture. How does Crohn's disease usually present? Crohn's disease of the small intestine.
Usually abdominal pain, constitutional
If there is abdominal pain, what does it mean? If there's
Most
only
common
diarrhea, what
presentation
does it
is abdominal pain.
pain.
Okay, second,
Second, diarrhea may present as diarrhea.
but how often they have this type of diarrhea?
Yes, sir. Not a combination.
Hmm.
Usually, small bowel type of symptoms would be predominant.
Which one? Which one is this?
Small bowel,
Of Crohn's. You're talking about Crohn's or what?
Crohn's.
Yeah, he's talking about
So you're
Crohn's.
saying it's a Crohn's small bowel diarrhea. So
Yes, sir.
no pain. What does it suggest?
So what? Pardon?
No, the patient has got only small bowel diarrhea without pain.
Yes, sir.
So what does it suggest? If it's Crohn's, what does it suggest?
Maybe a small intestinal bacterial overgrowth.
It's only so there's only a mucosal involvement and there is no transmural inflammation.
Okay.
If you're thinking of the pain, if there's a transmural inflammation, they'll always generally come.
Then pain.
I've not seen many of these Crohn's coming like this only with a mucosal involvement without transmural inflammation.
Usually it's a transmural disease.
Yes,
So
sir.
some degree of
Transmural
pain will be
more
there.
often.
Some degree of pain will be there.
Mhm.
Okay, so once you think it's a Crohn's disease, you think because there's inflammatory back pain, I think, and so it is Crohn's involvement.
Can this be anything else?
Differential tuberculosis.
How often is
Involvement of this.
tuberculosis coming with a large volume diarrhea for 6 months? No fever,
Rare,
no abdominal pain, no?
rare, less likely.
Then why do you say it's tuberculosis? How does tuberculosis small bowel present?
With
What is the
that
difference
present
between
in
Crohn's and tuberculosis in morphological involvement of the small bowel?
the ulcers in
Crohn's
tuberculosis
is a diffuse disease. It will involve multiple areas of
segments.
bowel, whereas tuberculosis is a locoregional disease.
Local.
It will be ileocecal. It will be
Ileocecal.
And how often have you seen diarrhea coming with this or 6 months history of diarrhea with a large volume in tuberculosis?
Not seen.
What else can produce large volume diarrhea and malnutrition? Patient is not having any features of osmotic diarrhea. Initially, he said fasting thing, but now there's no osmotic diarrhea. Patient has lost weight.
Yes, sir. Celiac, malabsorption.
Can be malabsorption. Okay.
Yes, sir. Then
In malabsorption, if you have, what are the causes which can produce this sort of diarrhea?
celiac disease.
Then tropical
tropical
also
sprue.
something. But if somebody you are thinking of a tropical sprue and patient develops pedal edema, what do you think is? Ipsin, immunoproliferative small.
Immunoproliferative small.
They go to that stage, they become malnourished. Okay. Focus
There again, this patient has got some colonic
Involvement.
manifestations of the mucus and oscillate blood at least in the last 2 weeks of the history.
Yes, sir.
Which is
Okay.
other condition in younger things they come with a large bowel diarrhea, small bowel diarrhea, large volume with all the features of malabsorption.
Common variable immunodeficiency.
CVID is one of the possibilities.
CVID.
You can get inflammatory bowel disease like picture. You can get small bowel involvement, large bowel involvement. So because she has had some ITP, she was given some steroids, she was given some immunoglobulins. I don't know whether she had it that time, and then she didn't have any diarrhea, but CVID can always have some IBD like picture.
Okay, sir.
Extra intestinal anything can produce large, small bowel diarrhea along with malnutrition.
Sir,
What are the diseases where you can have
Intestinal
extra
diseases
intestinal
which can
malnutrition?
produce small bowel diarrhea with malnutrition.
Graves disease.
Hmm?
Hyperthyroid.
Hyperthyroidism doesn't produce so much of malnutrition. What is the disease which can produce malnutrition with large volume, the extra intestine?
Neuroendocrine
Huh?
tumors.
Okay, you think of various endocrine conditions which can produce diarrhea.
Addison's.
One is the hyperthyroidism, Professor Venkat already mentioned.
Addison.
Okay.
Addison's disease.
Okay, but
Hmm.
recurrent diarrheal disease. Okay, one of the DDs. Okay.
Addison.
In next,
Neuroendocrine tumors.
like which tumor? What are the neuroendocrine tumors capable of producing diarrhea clinically?
And malnutrition. How does Zollinger-Ellison syndrome present? And
Abdominal pain.
malnutrition in that.
Abdominal.
Malabsorption in Zollinger-Ellison syndrome, what happens?
B12 deficiency.
See, when it's Zollinger-Ellison syndrome, there is a large amount of acid which is going into the duodenum. So when it goes into a large amount of acid in duodenum, what can it do? It can impair the missile formation. So you can develop steatorrhea. The same time it continues, you also can develop over a period of time protein losing enteropathy, like picture in Zollinger-Ellison. Any other thing in a small girl like this can come with a large amount of diarrhea, weight loss, volume, continually weight loss. Because
HIV.
about any,
HIV enteropathy.
Yeah, CID you told immunodeficiency states and HIV enteropathy. HIV enteropathy it is more common in HIV to come with enteropathy as diarrhea, or something else is more common to come with diarrhea?
Secondary infections.
Superimposed
Parasite,
infections.
superimposed.
And in which infections, which organism can produce large volume diarrhea with the dehydration and renal failure in HIV patient?
Cryptosporidiosis.
Cryptosporidium can cause, isospora can cause. Anything else, an extra intestinal disease which can come with a large volume diarrhea, weight loss, typically occurs in young females.
Not sure.
You do an ultrasound, there will be a small lesion in pancreas.
Pancreatic NET.
Huh?
Pancreatic NET, sir.
Pancreatic NET. Have you never heard of vipoma?
VIPoma. Watery diarrhea,
It's other
ichlorhydria.
synonyms are
Peptide. So these are the conditions which can really produce large volume diarrhea. And also, as Sir said about there's a bloody diarrhea, you also need to think of a large villus arenoma in the rectum. So I think this will be my this thing. Anything else, madam? Or...
What are the other synonyms of vipoma?
WDH.
WDHA syndrome. Burn. What is WDHA?
Watery diarrhea, hypochlorite,
And what is A? Sadguna? Watery diarrhea?
Hypokalemia and achlorhydria.
Echlorhydria. Okay. Then Werner-Morrison syndrome and pancreatic cholera. These are the other things. Pancreatic cholera, Werner-Morrison syndrome, WDHA, and of course, vipoma. VPoma. Okay. So, what about any? So basically, what is this, an inflammatory diarrhea or a non-inflammatory diarrhea?
Inflammatory diarrhea.
What are the other? Okay, one is we consider IBD, Crohn's disease. Crohn's disease affecting the small intestine as well as the large intestine, possibly affecting up to the lower region because of the increase very high frequency. Usually, very high frequency occurs when there is a rectal involvement. Extremely high frequency. But even if there's a colon involved, this much high frequency is unusual unless the rectum is involved. That's the usual pattern. Okay, now can this be eosinophilic enterocolitis?
Can be.
Theoretically, but practically we don't see much eosinophilic enterocolitis. I have just seen 3 cases in my entire career. So it's a rare condition. If you are just asked, is there any other inflammatory like that, you can ask. Okay, non-inflammatory, which are the ones which will produce small bowel diarrhea plus arthropathy?
Whipple's.
Louder, please.
Whipple's disease.
Whipple's disease. Yeah, Whipple's disease again. We have not seen. I haven't seen much. I have not seen a single case. I have seen a case presented. So rare condition for us. But again, profound diarrhea, malabsorption with joint involvement. Any other condition where we can have joint involvement?
Lymphoma can.
Lymphoma. Lymphoma joint
Paraneoplastic.
involvement, I am not so sure. Perhaps when they are treated, they may develop some uricosuriia and hyperuricemia, etc. But not
Which is the other small bowel diarrhea, which can cause multiple other symptoms, extraintestinal symptoms. They can come with anemia, they can come with thyroiditis, they can come with autoimmune hepatitis, they can come with arthropathy, they can get ankylosing spondylitis. Which one? Which is the disease? Which?
Not sure.
Celiac disease, no?
Celiac.
Celiac disease can come without diarrhea, it can come with anemia, it can come with unexpected hepatitis, it can come with arthropathy, it can come with thyroiditis. All these things are associated. You should not.
Celiac disease has changed its clinical manifestation. It can occur in obese people, it can occur in normally weight people, it can produce a non-diarrheic manifestation. So many different manifestations are there.
Of celiac disease.
The classic celiac was the one which was always with the classic steatorrhea, malabsorption, etc. That is gone. World over, they have now found out that a large number of people, even with obese people, can have some manifestation. Normal weight people can have some manifestation. They can just present with anemia. They can present with any other features. Skin manifestation, so many things. Like
this is not this thing, I think multiple things. They can present with joint pains always.
So can it be autoimmune SLE underlying with superinfection?
what is that? Louder,
Autoimmune.
please.
So autoimmune underlying SLE young female with the superadded.
SLE involving the GI
There are no
tract
other
is
features of SLE here. She didn't have skin rash, anything like that.
SLE.
Some back pain. You
It is
can
generally no.
put it
SLE,
as
in spite of its systemic involvement, its involvement of GI tract is not that
not
phenomenal.
alone. Yeah, without system, you will go.
That's
Don't
the
get
one usual
diarrhea.
picture. If you
may-
ask us, autoimmune enteropathy associated
correct.
with the other form of autoimmune disease, very rare, but nowadays increasingly reported in the literature, like autoimmune enteropathy may be there. Then another thing
Autoimmune
which we
enteropathy you
miss-
can think of. Yeah, you can.
yeah, autoimmune enteropathy can also produce arthritis. Probably your earlier ITP also may be related to that, but there's a long gap. There's a long gap between that and subsequently. Can drugs produce a picture like this, enterocolitis? We didn't consider that at all.
Large
She's not
volume
taking
diarrhea,
any
which
drugs,
can
but for a
produce.
theoretical sake, can drugs produce enterocolitis?
No, name one drug which can produce flu-like illness.
Olmesartan induced enteropathy.
Olmesartan, telmisartan, all these things can produce.
Can drugs produce colitis? Can present with the blood in the stools?
NSAIDs.
Pardon?
NSAIDs.
Yeah, NSAIDs are capable of producing colitis. Yeah. I think we had an exhaustive list, and now just to summarize, just tell us the DD 1, 2, 3. Most likely diagnosis.
First will be IBD Crohn's disease.
Involving?
Involving small and large bowel.
Small and large bowel with extraintestinal manifestation in the form of
Arthropathy, inflammatory
arthropathy
oligoarthropathy.
and with the profound probably hypoalbumic protein,
Hypoalbumic.
enteropathy. Okay.
And
Second,
pancytopenia.
DD.
Second will be common variable immunodeficiency.
Okay. The only thing is that she did not have any respiratory infection during her childhood, which is quite common. Upper respiratory, sinusitis, bronchitis. By this time, she would have developed bronchiectasis, all those things which are missing. Okay. Regarding tuberculosis, one thing, if a person with a HIV with the low CD4 count actually develop tuberculosis, at that point of time, the type of diarrhea may completely differ from the classic HIV in an immunocompetent person. In an immunocompetent person, the most common type is ulcerohypertrophic. Actually, this hypertrophy, etc., is part of the tissue reaction. It's only okay. In a completely or in a completely immunocompromised person, the lesion tend to be mostly ulcerative, extremely ulcerative form, and in which case perhaps the diarrhea may be a little more watery and not the classic type of diarrhea which you get in tuberculosis. But it has to be advanced HIV disease. That's a situation where you have purely ulcerative. We have discussed ulcerative, ulceronodular or ulcerohypertrophic, and purely hypertrophic, that is stenotic with strictures. Okay, then you said IPSID. Okay, IPSID, but unfortunately, IPSID is not a disease which is not seen in this part of the world. It is mostly seen elsewhere. Okay, celiac disease with ulcer. There is another condition called ulcerative jejunitis. No, severe
non-specific ulcerative.
Non-specific ulcerative jejunitis.
But they come with a lot of pain.
Sadguna? You have written celiac disease with ulcerative jejunoileitis.
Sir, this case actually 1 month back I have seen, sir. At the time I have prepared this PPT. At the time I thought that initial 4 months she told that with fasting it was okay. I thought it might be celiac. For the past 2 months it was like completely explosive nature. So it might have turned into, but generally it's not the presentation. Long-term celiac, then only ulcerative jejunoileitis or EATL. But I consider this lower than.
Occurrence of a lymphoma on top of celiac disease, the manifestation may differ. They may have pain and other things. But ulcerative jejunoileitis by itself can present as a very severe disease. Very severe disease with profound malnutrition, protein-using enteropathy within a short period of the onset of illness. I think whether it is a celiac or some other idiopathic entity is still questionable, because the final word is still not there regarding the severe ulcerative disease of the jejunum.
There is history of wheat intolerance, this patient?
No, ma'am.
No.
No, ma'am. No.
So on what basis would you consider celiac disease, and how common is it in your place? She's from Kerala,
She's
is
from
it? Or
Chennai,
where?
ma'am. She's from Chennai.
So what is the prevalence of celiac disease down south?
A 0.1%.
Dominant
Around
wheat eater
0.1%.
or a
Not
rice eater?
1%.
What is the study? What are the studies that have shown about celiac disease south versus east versus north, west versus east versus north, east and south?
Studies, I'm not sure, ma'am. But 1/10
So,
of the
so
north
from
prevalence,
south,
it will be south.
basically, we have the HLA DQ, we have the HLA, but we don't have celiac. We have yet to report one celiac from south, from Tamil Nadu, not even one case reported as yet. There is one paper by Dr. Malti, and that was in a patient who was from Rajasthan, that family. It's only that particular family. We have yet to report one case of celiac disease. Whatever cases are being reported, say from Vellore and all, are people from other states. We are yet to report. I just want to check with the others whether they have seen a celiac.
No.
We have yet to report.
But you
One
are
case was presented in ISGK Kerala chapter in a person who was born and brought up in Kerala, but subsequently went to Gulf and he changed his dietary habits completely. And from there he developed diarrheal disease, and subsequently it was evaluated and found to be having celiac disease. But then he was a wheat eater, not a rice eater.
Yeah, we have the genetic predisposition, but we have yet to report a case here.
So is she a rice eater or a wheat eater?
Rice eater.
Rice eater, then that should not be anywhere in that list. Rice or any other things which contain gluten, no? So unless that is a predominant diet, we cannot entertain it. So we cannot entertain it purely for theory. because it has to be for this particular case. The list of DD now shown should be pertaining to the case, and it should not be a general list at all.
I kept multiple rare conditions because she was already evaluated outside hospital, so they couldn't come to a more general diagnosis. I thought that if we are not getting the first two differential diagnosis, we need to think of all the rare varieties also in this patient.
Okay. Suppose you didn't get a chance to defend it, but usually the other thing you should mention and immediately say that it's unlikely because of either rarity in your locality or due to any other thing. Whenever you present, whenever you think it's a very rare condition, you must be hesitant to confirm it as your first diagnosis. Okay. So rare things are rarely correct. That's a common dictum. Second, if it happens to be the thing, suppose it happens to be IPSID, and you strongly argued for it, the examiners feel that you actually had inside information. That's it. That's how they think. They will not get much credit for that. Okay, so we actually appreciate the way in which you discuss. How strong are you to approach the problem and how you approach the case as such. It's not the particular diagnosis we are not bothered. The differential diagnosis, how you defend, how you tell the most likely diagnosis. Okay, never bring a very rare diagnosis as the first one. In the end, it may be you may be right, but still that will not be the way which will be accepted in the examination. Okay, can we proceed? Shalkuna, can you tell the physical findings?
Yes, sir. On examination, patient is moderately built, looks emaciated, weight is 32 kilograms, height 152 centimeters, BMI was 14, and in our hospital, pulse rate was 92 per minute, normal volume and character.
I would have corrected BMI.
BT,
Yeah.
Can each of us consider a differential for this patient before I do not know the case, okay?
I also don't know.
So none of us know. So can we just tell what will be our approach?
I will consider Crohn's, still Crohn's disease affecting the small and large bowel will be my first diagnosis with the extra-intestinal involvement.
Yeah, for me, number one would be some behavioral abnormality where she has this watery diarrhea, lack of intake, anorexia, and she has this disorder. The blood in the stool mixed and all can again be a disorder with a laxative abuse will be my first DD, this patient. Number two would be in the presence of the mucus that you're saying, I have to see to believe it, okay? If she's passing 12 times a day, I'll just ask her to pass some stool in front of me and just see how much of mucus is there. That is the proof of the pudding, no? That will tell us she's passing so many times, she can just pass on a small motion and just show what it is. The other differentials, I just am not able to, or there are two different entities. She's had an ITP and she's had an immunoglobulin then. So is she, I do not know much about ITP, but is it some immune deficiency state that she has? And therefore she has immunoglobulin deficiency, IgA deficiency. She's got some strongyloidiasis like hyperinfestation, and she has this watery malabsorptive type of diarrhea. And then it can usually colonic symptoms are uncommon in strongyloidiasis. So that comes down in the list. The other DD, what I would consider would be maybe NET, but I'm not able to explain that. With absence of pain, inflammatory bowel disease to me is just unlikely in this patient. And I still feel there'll be an SRUS, she will be digging her this thing, and that will be my first DD in this patient because she's been extensively evaluated, he said, and they've drawn blank. So my DD would be behavioral with an SRUS component. Number two,
amenorrhea.
One minute. I'm just listing. I'm not saying anything. I'm just listing my differentials. Dr. LBK also has to give his list so that we know how from this side we're thinking. And then the third, is it an NET with large volume, but there's no dehydration, admission. So I am a little skeptical about the whole, for me, it is more towards eating disorder, behavioral disorder. My shift will be towards that as the first. Number two would be immune deficiency state. There, I would really like to know what's the scholastic history. How was she during her behavior? Was she in school? What was the scholastic history? How was she till +2? How did she perform in +2? And now she's 18, so she's just gone to the college. Is there any other problem in the college? Is it what do you call that? A school where you have the problem in this college that she has, this thing. So these are the things that co-ed, is it a co-ed college? And therefore there's some other problem which is not coming out. LBK, your differentials?
So I think first I would put it as one could be a CVID. I've not seen really behavioral disorders. Number two, IBD, I would consider both involving small bowel and Crohn's. Third, I would like to rule out some extra intestinal, like a white moma or something like that. Because all these things can also go on.
Yeah. Okay, now you can proceed.
If
Okay.
if
For me also
lymphoma,
IBD
you have to
first followed by
consider
CVID. And of course, some rare parasitic infestation. We had a case at Trichy where
strongyloids.
strongyloids, in fact, it was a Capillaria philippinensis.
Hyperinfestation and
Capillaria.
capillary.
Okay, eating some partially cooked food from street side. The person
Capillaria
developed
philippines.
profound,
Yeah.
profound.
Another place.
So strongyloids, capillariasis rarely can produce all these manifestations.
Strongyloids we have seen. There can just look like. In fact, once when we did one in Vellore, when we did a barium meal follow through, it was all completely featureless. And they said it could be strongyloids, and ultimately.
Okay, now we can ask them to tell what it is. So these are our DDs.
Okay, Sir Guna.
Sir, I have one doubt, sir. When putting the differential diagnosis, because this patient also had amenorrhea for the past 6 months, we need to put it as a second disease, or
Most probably in a malnutrition will be secondary amenorrhea.
Okay, malnourishment
Somebody has gone on for so many times.
Okay, I think because of amenorrhea, hyperproteinemia, because of extensive field edema, weight loss, I think an organic disease will have to be strongly considered. That is
common in anorexia nervosa. Okay, amenorrhea. It's a common feature of anorexia nervosa.
Okay, anorexia nervosa is a eating disorder, but ma'am, there will be some history of the eating disorder in the past.
They'll never come out with any history. Nothing will come out. Anyway, let's continue. I mean, I'm just thinking my mind aloud, just my suggestion.
She had conjunctival pallor and pitting type of pedal edema present up to the ankle, and entire skin is dry and scaly. No bite out spots, bony tenderness, petechiae, no oral ulcer, scolitis, or stomatitis. And per abdomen examination is normal, sir. Abdomen is flat.
Did you find anything abnormal?
No, sir. Bowel sounds also appeared normal at the time of examination. Per rectal examination, perianal examination also normal, sir.
Okay. Other
Respiratory system examination, cardiovascular system, and
joints.
Sir.
Did you examine the joints?
Sorry, sir.
Joint spine, because we are considering extra intestinal involvement in the form of arthropathy, no? Examination of the spine, examination for looking for sacroiliitis, looking for arthritis. Once you are committed to that, then there should be some, it's present or absent must be there. Okay.
So except anemia, there was nothing else.
Anemia and pedal edema. And dry skin, scaly skin.
Low BMI, anemia, low BMI, in spite of edema, bilateral pitting pedal edema.
And scaly skin.
Glossitis.
What was the
then the scaly skin. No,
what was the frailty score? Frailty score and sarcopenia index. And her performance and a performance.
Her performance status ECOG 3, ma'am, because she was most of the time she was bedridden. Most of the time
when you saw her in the OP, she was bedridden, no?
It was not OP, ma'am. She came to emergency from outside hospital in ambulance.
For what?
In the outside hospital, she was admitted for 1 week.
Emergency for what?
She was referred from other hospital to here, ma'am, for further management.
She came to the ED with severe diarrhea. Is that what you are trying to say?
No, sir, she was admitted with these complaints. She was evaluated. She has given some treatment. So they were not satisfied.
So she was not a walk-in patient. She was
not a walk-in patient.
Yeah, okay. Agree. Okay, any other physical findings you want to tell? No,
sir.
I think the next person will have to come up and tell us how you investigate.
PT, was she communicative? 1 minute. Was she communicative?
Yes, ma'am. She was communicative.
She was communicating. She could tell the history herself, right?
She could tell the history, ma'am.
And that she was, I mean, she could speak loudly and clearly.
Not loud and clear, ma'am. Her mother is there, so she is also helped her in telling and also confirming the findings.
Mother, anyway, I'll discuss it later. Okay.
What is Manjosam syndrome?
That is a psychiatric problem. Repeatedly consulting doctors for multiple complaints.
What they do regarding the symptomatology?
Symptomatology, they fabricate.
Yeah, they fabricate symptoms and sometimes even signs, especially stools and all, they will add water and try to make it watery. Do you know about reverse Manjosam syndrome? I don't know whether terminology is correct, but sometimes the mother
Manjosam
wants to be in the
syndrome by
hospital
proxy.
and in the committee, in the sort of company of medical people. So that's usually pediatric kids are brought to the hospital with the various complaints. And so the mother will be in the hospital most of the time in the company of medical, paramedical people, and they enjoy it. Okay. Okay, the next person to discuss is Prasuna from Pushpagiri, Tiruvalla. Dr. Prasuna, are you there?
Yes, sir.
Yes, please. Please switch on your audio video.
Sir, first I'll go with investigation, routine basic investigations like CBP to look whether thrombocytosis, anemia, and leukocytosis, sir.
What type of anemia you
And
expect?
raised microcytic hypochromic anemia because malabsorption is there.
So you only expect microcytic
And sometimes
hypochromic.
vitamin
Pardon?
B12 deficiency, macrocytic.
It's only
or
vitamin B12
dimorphic-
deficiency which can
dimorphic
produce.
anemia.
See, no, don't be very fast. You have to be sufficiently, the speed must be sufficiently sufficient that we also must be able to understand what you are talking. So anemia can
Sure.
be of any type. It can be microcytic, it can be macrocytic. Macrocytic can be due to folate and vitamin B12 deficiency, or it could be a dimorphic type.
Vitamin B12 deficiency.
Okay, so
Dimorphic.
that is how you have to go.
Yeah.
What about WBCs?
Yes, sir, leukocytosis may be there.
Why? Is there any situation where there was a history given that her blood count was low? At the age of 80 years, she had ITP. Probably it was only platelets.
Thrombocytopenia.
Yeah, it was platelet. But is it possible that
Yeah.
WBCs can be low in the blood? Okay. Can eosinophils change? We are considering parasitic disease also, no? So eosinophilia can be there.
Yes, sir. Eosinophilic count. Eosinophilia may be there, sir.
Okay. So just can't be just go pass off
Yeah.
or a brush it off. So each point you can be sort of stopped and ask question. So routine test. Okay, fine. Next. Next, what will you do?
ESR, sir.
So non-specific
whether
indicator.
islet
Okay.
raised. Yeah, CRP
Any
levels.
other? Okay, CRP, another non-specific indicator. Which all situation you expect the CRP to be
Fecal-
elevated?
Sir, IBD, sir.
An inflammatory disease.
Inflammatory
Suppose it is
diseases.
a purely mucosal disease with only some like celiac disease. I do not know much whether CRP will be elevated, but should not be. So here inflammatory component, if it is there, okay. Then what else?
Fecal calprotectin levels.
Before that,
Any,
we will
Patient has got edema now.
pulmonary lab.
before that, edema, yes, sir. LFTs, I'll look for LFTs,
Why do you want to look for
hypoalbuminemia.
liver function in this patient?
Sir, IBD may be associated with PSC, primary sclerosing cholangitis, and here she is having edema, so I'll
Madam,
be looking
here is
for
a patient who's got a
hypoproteinemia.
chronic diarrhea. He has got, if the alkaline phospho elevated, what is the possibility when he's got a malabsorption? What will be the
Malabsorption.
Alphos is elevated.
got anemia.
Transaminase. Okay, suppose we will say transaminase is elevated. Alphos is elevated. Transaminase elevated 3-4.
When patient has got a malabsorption, the most common cause of raised alkaline phosphate in this situation would be a vitamin D deficiency.
Vitamin D deficiency.
Why do you go from here to this thing? We are thinking of a lady who's got a chronic small bowel diarrhea with plus minus involvement as well. But here, and she is malnourished because of and she has got pedal edema. That means you will expect her albumin to be low, and if the alkaline pulse is elevated, you need to really think of vitamin D deficiency in these patients.
Okay, so liver
Thinking
biochemistry.
of Crohn's
is
and
ideal
PSC.
test. Next one.
Yeah.
Renal function test, because she's having chronic multiple episodes of diarrhea. We have to rule out any AKI, renal failure, and
Okay.
electrolytes to look for
Okay,
hypokalemia.
electrolytes, agreed. Anything else? From your ordinary lab?
Like we have to check for, because we are suspecting CVID, any globulin levels, decrease in globulin levels.
Okay. I think the test will have to be planned in such a way that if what is commonly done should be done first.
Stool
Okay.
examination.
What about stool?
Full
Stool
examination.
examination. Will you
Stool
not
Stool examination.
Microscopy and microscopy. Tell us how you examine the stool.
Ask the patient to pass stool and see what it is. Or
First
just see
is
it under
the
undergarments. no?
freshly processed stool, and you have to get an idea. The patient will be telling so many things, but when you see it, you will get your own idea. Number one. Number two, then microscopy. What all things you look for?
Sir, WBC count, RBCs, any OVA, parasitic.
Over parasites, and in this patient, what will you look for?
Rights.
Huh?
Just an ordinary microscopy, you didn't find any ova parasite. So that will, did that rule out parasitic infestation?
No,
Which
sir.
all parasite you are specifically interested in this case? Are you interested in seeing a round?
Okay, I say, how do you detect strongyloids in the stool?
Strongyloids in the stool.
What is the finding in the stool will tell you that this is a strongyloids infection. Is it ova or cyst or anything else?
Anyone can answer. Satguna, Jovita.
The infective form is filariform larva.
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 So if you see larva, it will be strongyloids.
Okay. There is a fallacy for the larva also. What are that fallacy? If you find a larva, okay, fine. But there is a fallacy for that. That means if the stool has been kept outside for a longer period, and if it contains hookworm ova, the hookworm ova may hatch and again a larva can form. Okay, so it has to be fresh sample. If the sample remains outside for one day or so, this can happen. So it has to be a fresh stool sample showing the larva, then it is very likely that it is strongyloids. Okay, stool for ova, parasitic larva. Okay, then do you do any special techniques to detect some other organisms? Or just ordinary
In
microscopy?
repulsation,
Detect cryptosporidium. How do you detect?
How do you find cryptosporidium? How does it look?
What is the stain you use?
Gimsa stain.
No. Anyone else?
Modified acid first.
Modified acid
AFB,
first
yeah.
staining. Yeah, modified acid first staining. Okay. Yeah, not Gimsa. Okay. Then stool. In a chronic diarrhea case, what all additional things you should look in the stool?
Sir, any Clostridium difficile infections?
Oh.
Before that,
Do you look for stool?
but under microscope, it is not
Just what do you
possible
look
to
for
find out
Clostridium
Clostridium
difficile?
difficile, no? No, suppose the child is presenting with chronic diarrhea, what all additional things you will look? Look for stool pH.
Stool osmolality, stool
No, stool
pH.
pH, stool reducing substances. These are the common things which you can do it in your side lab. Okay, this modified AFP staining, modified acid fast staining may not be possible because they will not be knowing it. But other than that, the microscopy, stool pH, stool reducing sugars, all those things can be done. What is the relevance of pH? What is the relevance of reducing sugars? Suppose this is a younger child. monosaccharide or
Osmotic
disaccharide malabsorption, no?
Malabsorption.
Yeah. Carbohydrate malabsorption, especially lactase deficiency or other monosaccharide, because there can be sucrase deficiency and situations where the child may present with diarrhea soon after stopping breastfeeding and starting milk with the sugar, etc. Okay, so reducing substances and low pH generally suggests carbohydrate malabsorption. What else in the stool you will look? Or RBCs, WBC you already
WBC.
mentioned. Overcyst you
Look
mentioned.
for what is called as a bacillary exudate. Is this because you said there was a thing, is there any RBCs, WBCs? All those things we need to look.
Okay. Then of course, if your laboratory has facilities, you can look for fecal calprotectin. And even if there are no RBCs, stool OB can be still done, because stool local blood will give us an idea that there is possibly oozing of blood that suggests that there is a mucosal disease. Okay.
Can we
Then
have the
stool
results? Sir?
calprotectin.
Outside hospital report, sir. 1 week.
Can the other person read it out? Prasuna.
Sir, HB was 10.8, MCV 75.9, MCH 26.9. Total leukocyte count was 2,400, platelets 33,000. Peripheral smear was showing normocytic, normochromic RBCs with few macrocytes and elliptocytes with few reactive lymphocytes. Retic count was 1.5, ESR 38, total bilirubin 1.1, protein was 6, albumin 2.6, globulin is 3.4, OT and PT was 22 and 23, ALP was 126, GGT was 132, creat was 1.0, urea 43, sodium 135, potassium is 3.5.
So what does it show?
What does it show?
Sir, it's showing anemia, probably dimorphic anemia, sir, because MCV is also decreased. Normocytic, normochromic anemia with macrocytes and elliptocytes, which is showing vitamin B12 deficiency.
Is it
ESR is
TC of 2,400 and platelets
Platelet of
33,000?
33,000.
Is it not the typo? Is
pancytopenia.
it the correct one?
Pancytopenia is no, sir. Pancytopenia is present.
Okay.
ESR is mildly elevated.
So she's got a
Hypoproteinemia is
pancytopenia, the chronic small bowel diarrhea.
Which are the situation where the
other test will tell
WBCs
you.
can be less in a person with a protein losing enteropathy? That was a big clue.
So what will
Can
you
you lose
look at
WBC
the
through the
patient?
gut?
Huh? What will you go back and look at the patient clinically? Diarrhea, pancytopenia, macrocytosis. Clinically, what would you have gone and looked back?
Features of B12 deficiency.
Huh?
Features of B12 deficiency.
What is it? What is it you see? What is the thing?
Hyperpigmentation of the knuckles, palms.
Which was there, okay. So what next test you will do here?
Will you proceed further?
Which will tell you that we are probably dealing. So
Or is it enough?
means that's a bone marrow problem. No? There is no this thing in bone marrow. So what's the next test you will do? Please don't change the slide. Supposing I order for LDH, what do you expect? What do you expect of LDH in a patient with? Do we have LDH in?
We have done LDH, sir, but in outside.
You didn't do LDH in this.
We did LDH, sir. Outside.
How much was LDH in this?
Forgot, sir.
So what do you expect the LDH to be here in this patient?
LDH is elevated.
Elevated means how much it will be elevated? 300, 400?
No, sir. In the hemolytic.
Thousands, actually it will be in
thousands,
thousands. This shows as pancytopenia, ineffective bone marrow if you're ineffective bone marrow regeneration, so it can have an LD. Okay. Look at the stool. What are the
Just tools.
patients we have
Just
done?
tools.
Outside hospital, they have done
We
colonoscopy
have
and
done a
CT,
stool
sir.
routine.
Our our
Okay.
hospital findings, yes, still there is pancytopenia. LDH was normal. Iron deficiency was there, and albumin was 2.6. And then stool
What
exam.
was the
Ma'am?
ferritin?
Ferritin 733, ma'am.
So now, based on the diagnosis that you had listed, what are the things that get excluded so that you go for the next investigation? You had that list, no? What are the things that get excluded straight away? What was the stool examination? Tell us that.
Stool examination was normal. 2 to 3 pus cells, 1 to 2 RBCs, mucus.
So now, based on your list, what all gets excluded so that we investigate which system now? Be fast. You had that list, no? You had Crohn's, you had tuberculosis, Behçet's, and Nautel. Which are the ones that get excluded? And a past history of ITP. Okay, keep that in mind. Now, we have IgG, Ig, and IgM.
No, ma'am.
So we don't have.
We don't have.
What are
Without
the
that, it
conditions-
will not be possible to diagnose common variable immunodeficiency.
What are the conditions that get excluded straight away? IBD gets excluded near about. Tuberculosis gets excluded, or you still have those in DD? I just want to know, at this stage, your DD remains the same?
Fecal calprotectin value is
Normal, fecal
normal.
normal.
So that shows that
I
there's
would
no
have expected
significant
you to
ulcerative disease of the intestine.
be a small bowel, looks like on
So
B12.
it has to be non-ulcerative disease, which produces malabsorption and protein loss.
The stool we should have done and modified AFB. HIV is positive or negative?
Negative, sir. HIV, thyroid function tests, and ANA, dsDNA, ANCA, TB-ferron, HLA-B20.
Fasting B12, fasting B12,
Sir,
fasting
B12.
B12.
B12 was normal, sir. 1520.
Hormone profile. apart from thyroid.
1520.
Yes, sir.
Okay. Anything else? Imaging?
Oh, sir. Outside, they have done imaging and colonoscopy, sir. In colonoscopy, they told that.
What's the
scope pass-
imaging first? Imaging.
Imaging first.
Diffuse circumferential edematous wall thickening in ascending, transverse colon, and proximal 1/3 of the descending colon with surrounding inflammatory changes, mild ascites, feature suggest of, this is what they mentioned, impression they mentioned, feature suggest of pseudomembranous colitis.
What is
But
that?
this is not the
feature?
presentation of
Pseudomembranous?
pseudomembranous colitis.
Pseudomembranous colitis.
This is not at all the presentation
Not
of
at
membranous colon. So there is some thickening in the ascending colon.
Just an inflammatory change,
Inflammatory changes.
most
in the
probably.
colon.
Again, only edematous. They didn't say any sort of whether it is vascular.
Or enhancement or anything.
Hypoproteinemia. Hypoproteinemia.
Just because of hypoproteinemia, you have got this.
But only thing it is
I don't think
focal,
this is,
confined to some parts of the colon. Otherwise, we should expect it.
Pseudomembranous colitis. Do you think this is pseudomembranous colitis?
No.
Then what else? What else they have done? And they have not mentioned anything about the small ball.
Okay.
And
Looking at the small ball. Okay. What else
so
you?
they've done a colonoscopy, sir. Scope past Dr.
This is outside, no?
Outside, sir.
Okay.
Rectum descending colon was severely ulcerated with edematous mucosa. Sigmoid colon was normal. And histopathology, they have taken biopsy from rectum, which showed mucosal fragments with lamina propria showing increase in neutrophils, lymphocytes, focal cryptite is seen, no basal plasma cell expansion, cryptapsis,
The symptoms do not really say. Why do you think that rectum is ulcerated? Very simple. Do you think she has got only proctitis? She didn't have any history of any proctitis.
No history suggestive of.
So what do you think? Why is it the rectum is ulcerated?
Probably because of large volume of stool.
Stools which are going. Okay.
Stool.
Maybe sometimes the stools may be severely acidic also. Small absorption, you're gonna have a thing. So
Can it still be SRUS?
this is not
Can it
a,
still be
No, no.
SRUS?
Even descending colon
The
also
picture is not
ulcerated.
suggestive.
Colonoscopy. Now just tell the
Oh.
colonoscopy. What are the findings you will look for in SRUS on colonoscopy? What are the findings?
What are the mucosal abnormalities in SRUS?
It can be ulcerative form or hypertrophic form, or simple mucosal erythema might be seen.
Okay, what is this hypertrophic form?
There is a rare hypertrophic form of SRUS also, sir.
How does it manifest? What is the morphological appearance?
Morphological appearance, it will be looking like a carcinoma,
Polypoidal lesions.
polypoidal lesion.
Extensive, so it can be ulcerative. The solitary rectal ulcer syndrome is neither solitary nor confined to the rectum. It can be
Exactly.
there anywhere in the colon. It can
Yeah.
be multiple. It need
That
not
is
be
most-
ulcer. It
Yeah,
can
that's
be a
most
small area of erythema. It can be ulcer, or it could be multiple polypoidal lesions.
Most important, yeah.
Multiple polypoidal lesion. People may think large polyps may be mistaken as neoplasm, as you rightly said, or some other inflammatory diseases whatsoever. Okay. So biopsy is acute and chronic proctitis. Okay, what you people did?
what did you do?
After a blood investigation, sir. So we thought the initial, this was 1 month back admissions. I have taken the history and everything at that point of time. So because they mentioned pseudomembranous colitis, we just want to rule out the Clostridium C. difficile negative, fecal calprotectin negative, and viral markers ANA, dsDNA was negative. So we had a bone marrow aspirate because of the pancytopenia when she presented, because her total count was 1590 and platelets were also low. And bone marrow aspirate showed mildly hypocellular particles, and erythropoiesis is normoblastic.
Why did you repeat an upper J and colon here? In this
We have repeated, sir, but after this we repeated. She was bedridden. So for the pancytopenia, infectious, and absolute neutrophil count is also less. We thought
No, this just shows some sort of mild.
nothing was significant, sir, in bone marrow. And upper G endoscopy, very few erosions seen in D1, D2 junctions, nothing specific, sir.
No. Did you look at the villi properly?
Yes, sir. Yes, sir. We were thinking of.
You should see when you do an endoscopy in a small bowel diarrhea. What do you think you look in endoscopy?
Endoscopy first, duodenal mucosal folds. Was there any?
So how will you look at the duodenal mucosal fold?
Is there any scalloping of the folds? Is there any?
No, so scalloping is not properly seen. How will you highlight the scalloping?
What are
Underwater.
the methods of highlighting the villi?
Underwater, we can.
Yeah, you push some water and see.
You
One
can
is
push
scalloping,
water.
you'll see. Second thing, what will you see?
Magnification.
Full villi blunting, you will see. Third thing, what else you will see?
We were thinking of.
This is of lymphangiectasia.
ulceration.
You will see any white droplets. Is there any?
Yeah.
Is there something which?
Small
you see?
whitish elevations.
All these are part of malabsorption.
Yes, sir.
With the current NBA, we can switch on the NBA and magnification. We can also
Magnification.
look at the villus size. If you're regularly using NBA when you reach second part of duodenum, you know the apparent length, and then you can
So
immediately.
kindly go through the NBA findings in malabsorption. There is an article in the World Journal of Gastroenterology. You just seen
Okay.
evidence in D1, D2. Okay. Did you take D2 biopsies?
Yeah,
So
they
we
took
have taken,
biopsy.
sir.
Let us see
We have
about it.
taken D2 endoscopy biopsies. Sorry, sir. My slide it is not proper.
Endoscopy of D2 is showing normal pattern.
Yes, sir. Probably mild chronic non-specific duodenitis.
Okay, so
Preserved
nothing.
villus crypt
Wait, let's
architecture.
go through this. Lamina propria shows mild plasma fusion. No increase in the.
Preserved villus crypt architecture. No negative for intraepithelial cells. No lesions in the lamina propria. Okay. So that means that is normal.
Yes, sir. In D1, D2 junction, mild erythemas, which was also not specific. So we had taken.
Some dilated lacteals.
Did you do an immunoglobulin profile? IgG, IgA, IgM, and IgE?
No, so we did not do the immunoglobulin profiles.
Should have done this. No? Should have done this immunoglobulin. Okay, next, what did
Do
you
you think that the dilated lacteals are important in that biopsy?
Only focal dilated.
Yeah, it's only a focal
lacteals,
thing. That's it.
Focal thing, it's not significant.
Okay.
So colonoscopy, because they passed only up to the splenic flex, we did a colonoscopy. Patch in, previously there was severe ulcers they mentioned, sir, but now patch inflammation in transverse colon and also a terminal ileum was inflamed with few erosions. Terminal ileum biopsy gene expert was negative. And the histopathology, these were the small erosions we could see, sir. That's it. Otherwise, the rest of the colon appeared to be normal.
So that means in spite of having such severe symptoms, the findings on colonoscopy are very minimal.
Very
Yes, sir.
minimal.
Very minimal. Okay.
Minimal. Okay. So from the
So
ileum
she
report,
got a behavioral disorder, as madam said.
no, sir. This
So nothing is there. So there's duodenal biopsy,
nothing.
colonoscopic, no biopsy.
Colonoscope biopsy is
You
also
repeat
nothing.
imaging here, your place.
No, sir. We went with PET CT, sir. PET CT showed faintly FDJ with diffuse circumferential wall thickening with submucosal edema. A possible IBD they have mentioned. In few prominent mesenteric and para-aortic nodes, no significant FDJ uptake. Minimal peritoneal thickening with mild ascites. And diffuse low-grade FDJ uptake in the mid and lower thoracic esophagus up to OG junction, likely inflammatory. This is what they mentioned.
Her lymphocytes were 55%.
Sir?
No, in spite of this, you do not look for serum IgA, IgM, IgG.
No, sir.
Because we are not able
Make
to
a-
find out.
you can make
This is some
the
non-specific
CT.
changes, non-specific thickening on CT, non-specific changes on endoscopy, non-specific changes on biopsy. Okay,
Biopsies
so
are not
actually we
shown
are not
anything.
hitting on the right diagnosis.
On the
I think
second
we are getting at we should look at the IgG, IgM, IgE, Ig levels.
on the second admission, we tried to look, sir. So
Serum
this admission,
chromogranin.
serum chromogranin was negative, sir. This patient, first admission itself very good. Serum chromogranin negative.
So what are we? Where are we here?
Sir, this was last month, sir. She was discharged, and rheumatology opinion and multidisciplinary team opinion was taken. So we couldn't come to a conclusion and kept a diagnosis of inflammatory enteropathy with inflammatory spondyloarthritis, HLA-B27 negative, and started on steroids and sulfasalazine, sir. So she had about 50% decrease in the symptoms and got discharged, sir. And 10 days back, she was admitted with a venous stroke, sir. So she was diagnosed to have APLA syndrome. Then there was nephrotic range of proteinuria. A lupus nephritis was there on kidney biopsy. So she's in ICU, sir.
She had a cerebral venous embolism.
It's got nothing to do
cerebral
with,
venous thrombosis.
it's got nothing to do with the
Thrombosis.
patient. It's got nothing
And
to do with the
kidney biopsy showed
Lupus nephritis, and actually ANA dsDNA was negative, Smith was positive, and antihistone was positive. So finally we concluded that it was SLE with probably GA involvement. Now the GA now with this admission, GA involvement not significant. She had she was in ICU. So
in the presentation, she's got nothing to suggest an SLE, and for the clinical
Or an
presentation.
APLA syndrome.
Absolutely, and this is not the presentation of APLA. If she has thrombosis here, she'll have thrombosis elsewhere. She'll have arterial here, there'll be arterial elsewhere. This is not, can it be an incidental APLA? How often can you get a false positive? Which are the parameters of APLA that were positive in this patient? How do you classify that APLA? Which are
primary
the-
APLA syndrome and secondary APLA syndrome, ma'am.
No. So I just want to know what are the markers you do for APLA?
Anti-beta 2 microglobulin and
Anticardiolipin.
anticardiolipin.
Actually, to diagnose APLA again, you need to repeat it after 12 weeks.
You have to
3
repeat
months.
it.
12 weeks.
Yeah, you have to repeat it.
You should repeat it after 12 weeks before you come to say it's an APLA.
3 months. After 3 to 4 months, you have to repeat it before you say it is APLA. She's bedridden. She's predisposed to thrombosis. Okay. She would not even been on heparin, this thing, she would not even been on prophylaxis. If she's bedridden, was she on prophylaxis? You said she's EPOC performance 3, always bedridden. So
No,
she's free.
she was not on prophylaxis. After admission here, we kept her on SCDs, ma'am. That's it.
Oh, even then,
Enoxaparin we did not give, ma'am.
all along, when she went home, she was walking. She went home walking.
He was able
Just
to
keep all this in mind. I think,
Yes, ma'am.
please
She
don't
was
get
able-
carried away by that APLA bit in this particular patient, okay? Let us not go with the message that this is a case of APLA presenting in this manner.
It's diarrhea, yeah. I
Yeah,
don't think
it is not, it is definitely not.
we
There's
are thinking
something
that it
beyond
is
that has been
lupus,
missed.
Apply
I
could
just
be an
want one
epiphenomenon,
message,
no?
only one message before others conclude. I always want to tell one thing. A similar case was presented at the gym in recently at Hyderabad. And we had a similar patient, 17-year-old, same volume diarrhea, same this thing. I just want to convey just one message. When a mother comes with this child, you know, or so-called this type of adolescent person, they'll always be protective to the child. They will never ever want to say the child is abnormal. Okay. So always keep this in this adolescent age between, you know, this transition from school to college. This is not for exam. I'm just telling in general. Be very careful about some sort of, so please read behavioral disorders at this changing, you know, the changing age pattern and the behavior pattern during the school days and switching over to the so-called adolescent versus adulthood. Be very careful. You have to spend a little more time and you will get that information. Just be careful. And mothers are always protective. And before concluding, I just tell once, yesterday I had a child. She's in 8th standard and the mother says she sleeps most of the day. Okay. On Saturday, Sunday, she wakes up at 2 o'clock. Other day she goes to school, but she comes back from school and she's being investigated for sleep. So these are the types of patterns we are seeing, you know. These are the types of, so just be aware, not for the exam point of view, but I'm just telling you in day-to-day practice, be aware of this particular issue that occurs. I'm sure VT and LBK will agree to this. We are finding this transition group, which is having such types of behavior abnormalities. You have to spend a lot of time. It may even take 2 hours to break this history out of her. And suddenly you'll find she's crying and you'll get the whole history will be out. Okay. That's my concluding remarks. And okay.
Only other thing is here, you should have done a CVID profile and
we have done, sir. Now this
probably
administration
if
we
you
have-
let us say this thing, but if your other thing is large volume diarrhea, you should have ruled out extra intestinal things. I think I would have ruled out Adenon probably looks carefully for a vipoma or something like this. It's very common in this particular age group before you think of. And the stool examination complete along with the stool, you should check what is called the osmotic gap. And if you're able to do that osmotic gap, it will tell you whether it's a malabsorption, it's a thing or malabsorption. And why is that she had a pancytopenia? Why did she have that 55% lymphocytes is something which
lupus.
No, such a
One
finding is
more,
not common
imaging-
for SLE, no? I
image.
think we are pancytopenia agreed it could be part of SLE, but a florid protein losing first and foremost G8 involvement in SLE, even in florid SLE is much less compared to other systems. So, second one is protein losing enteropathy presenting like pedal edema can occur, but there again it is in florid SLE with the classic manifestation and classic markers. This is a patient with practically all the markers negative. Only the kidney biopsy showed something which is suggestive of lupus nephritis. That's all, no? So I think we have to keep our eyes widely open
Anti-Smith antibodies,
for other possibilities
antihistone,
as well.
active. Sir, an exam.
But I want to congratulate Satguna for presenting such a tough case. The usual tendency for residents when they take their own cases is to present very simple cases so that they will get easily, no, it is a very easy walkover for the clinics. But Satguna, I want to congratulate you because you have taken a very difficult case, very difficult to discuss case and present it. And I should, no, hats off to you. It's a tough case. Professor Venkat, any further comments?
Nothing, sir. I think this is okay.
But whatever it is, I told you, know, in an examination, it does not matter what is the final diagnosis. It's the approach. You should have a very, very strong approach because if you say a calprotectin without routine stool examination, there will be empty number of questions. Okay, the
This
examiner
patient,
will
I
not
think,
tolerate it.
done a B12.
Examiner will not tolerate it. And in any diarrhea, please be ready to answer on stool exam. The entire discussion can be just on stool examination. Okay, you may ask us why, because the lab technician is going to do and I am not going to do in future, but only if you know how to interpret it properly, what comes from the lab, you will be able to make a correct diagnosis.
So here in the stool examination, we would have done a complete stool routine, modified AFB. If you think there was a malabsorption, you should have done a D-xylose, a urinary dixylose, and then you should look for a stool for fat globules.
How do you do D-xylose test, Sadhguru?
5-hour deadulism.
But I
Not
don't
idea.
remember, sir.
How do you do 72-hour fecal fat?
72-hour fecal fat, we know, sir. We
Is
give
there any
100 grams of
a
fat.
simpler test? Because 72-hour fecal fat test, otherwise known as Bandy-Kammer fat extraction test, okay, is very cumbersome and is practically not done except perhaps Velu. Okay, Calicut Medical College also, they were doing it, but now they are doing. Now what they are doing is acid steatocrit test, which is simpler, acid steatocrit. We can also find out semi-quantitatively by staining. What stain is used?
Sudan 4 stain.
Sudan?
3.
And examine under microscope for the size and number of the
Fat globules.
globules which you see. Okay.
Qualitative.
So please know all these things. Early D-xylose, fecal fat, the diseases which can be definitely diagnosed by a deep duodenal biopsy, the diseases which can be probably highly suggestive. All those things you should be able to rattle off.
And should a modified AFB should, and the stool examination should go on 2 consecutive days. This way, and then you do it. And then probably should have done one more imaging on that. And I've told the guy to look for any other one subtle lesion in the pancreas. That's also one.
What will be the lymphocyte count in a patient with a lymphangiectasia?
Peripheral lymphocyte count.
They will lose
No.
lymphocytes. So lymphopenia, that is why when you showed lymphopenia, that I got an alert. But then the bone marrow was abnormal. The lymphocyte can be lost because of the lymphangiectasia, like lymph varices. The lymph will be lost into the intestine and it will be lost. So protein losing enteropathy plus lymphopenia, both can occur. Which is a situation where you can have less round cells in the lamina propria on duodenal biopsy. Hypogammaglobulinemia, less number of immune producing cells. Okay. All right, please read up all those things. It was a nice case. Thank you.
Thank you. Thank you, sir.
We'll wind up.
Yeah, sure, sir.
Okay, thank you.